in the year. He completed a residency in Child Neurology at Rutgers University, New Jersey Medical School in Newark, New Jersey, and a fellowship in Neuromuscular Medicine at University of Rochester Strong Memorial Hospital in Rochester, New York. He also has post-doctoral research experience in child neurology at Duke University Medical Center. Dr. Veerapandiyan has a passion for clinical research and education. His clinical research focuses on neuromuscular disorders in children such as Duchenne muscular dystrophy, myotonic dystrophy, other muscular dystrophies like FSHD, LGMD, and so on, amongst many others. He has been involved in several industry-sponsored clinical trials and investigator-initiated projects in these areas. Dr. Veerapandiyan also has interest in research focusing on resident and medical student education and implementation science. He has published more than 25 peer-reviewed articles and has presented his work at national meetings. He is a member of the American Academy of Neurology, the Child Neurology Society, and the American Association of Neuromuscular and Electrodiagnostic Medicine at the University of Rochester Medical Center, Rochester, New York. We welcome you, Dr. Veerapandiyan, and thank you for taking time from your busy schedule to talk to the DMD community on a topic of utmost importance. Over to you, sir.
No, thank you. That was a lot, but thank you. And thanks all for joining at this time of the day. It's like, I think 9 p.m. I was thinking, rather than me giving a lecture or something, let's kind of have this as more of a conversation, and we can just kind of talk to you all, answer any questions that you all have, and I'm happy to share my opinion or my suggestions on anything. I thought that would be more useful than me kind of talking, giving a lecture or something. So yeah, we can start with any sort of questions about current trends in the treatment, what's coming up, what's in the horizon, and any questions related to treatment or diagnosis or anything.
Yeah, we do have plenty of questions that have been sent in at the time of registration. So I'll just read them out one by one. One is, can you explain about the new drug, which vamorolone, which is just out in the market, and if you can give us a brief explanation on that, that would be helpful.
Sure. Yeah. Give me 1 minute.
And so supplement to that is, how is it better in side effects compared to deflazacort or prednisone?
Yeah. So let me see if I could share my screen. I was going to see a brief slide on that. So the key thing that I always say is it is a corticosteroid. It's a steroid. It's not a steroid substitute, or it's not a or it's not something that replaces steroid. So it is a steroid. So it's in the same group of prednisone, deflazacort, and now this vamorolone. The difference in the structure is, I don't want to get into details. There's just one. They removed a little connection from a little ion, what you call little molecular structure. That's kind of removed. That's the only difference between vamorolone and prednisone and deflazacort. If you look at it is approved in the United States. They just approved it for age 2 and older. If you look at the effectiveness, how effective it is, it's pretty much on par. It's pretty much equal in terms of effectiveness with prednisone, Emflaza, or deflazacort, and vamorolone. They're pretty much on the same, equal. The dose, you can see that if you look at the FDA prescribing information, they approved it. The dose is split from 2 to 6. 6 milligram per kilogram per day dose is the ideal dose, and that dose has the maximum, has the better effectiveness. You can go down up to 22 milligram per kilogram per day, but that dose is obviously less effective than 6 milligram per kilogram per day. So when you come down to the side effects, so they had compared the side effects with placebo, meaning no treatment, and also with prednisone. They had not actually compared that with deflazacort, at least what had at least what had reported in the prescribing information. But what we know from the clinical trials that had happened so far is so the behavioral problems is lesser with vamorolone compared to prednisone. It may be as equal as deflazacort. Now, weight gain. So weight gain happens in all three: prednisone, deflazacort, and vamorolone. Maybe slightly better with vamorolone is slightly better from that aspect. The important things to highlight about vamorolone is it actually helps with the, if you look at prednisone and deflazacort, those boys who are taking that, they are shorter, and because it does arrest the height, so they're not growing taller. Whereas with vamorolone, what we have seen is it doesn't have that effect. So the boys who take vamorolone are actually taller. They have the normal height, growth velocity, normal height. So that's one key important thing. Now, how important is height? So that's something that's very personalized or very individualized, depending on the patient, the boy, and the family, right? Because there is this concept that if you're taller, there's a chance that you're more weaker than a shorter boy. So we actually prefer them to be shorter because that helps with the muscle weakness. So if you're taller, you may be a little bit more weaker than a same boy who's shorter. But then you have to take into the consideration what, sometimes that being short can have so much psychological impact on the boy. Then if they're taller, they can have more confidence. So it really depends on that individual person and the individual patient and the family from that perspective. Another key difference with vamorolone is the vertebral fractures. It does happen, but if you look at the data, the vertebral fracture burden is lower with vamorolone compared to prednisone and deflazacort. Those are the key differences. Now, the caveat here is we do not have long-term data on vamorolone. We do not have the effect of vamorolone on heart and breathing and respiratory muscles. But on the other hand, we do know prednisone and deflazacort, we do have data that shows that it slows down the onset of cardiomyopathy, it slows down the respiratory muscle weakness. We don't have that information for vamorolone. Of course, we can assume that as a steroid, it also does that, but we just don't have the data. So I know I spoke a lot. I don't know if that kind of gave you an idea in terms of the key differences between these three.
Yeah, thank you, doctor. And people generally are asking that why all gene therapies generally exclude deletions of 17, 18, or from exon 8 to 20, 18, that is general, or till 20. Why is
I think that's a good question. So again, I'm gonna go to let me share the screen and then I'll explain to you guys. Are you seeing a screen that shows the exons?
Yes, doctor, we can see.
Yeah. Okay. Sure. So the main reason is the safety, right? So with the gene therapy, what are we doing is, you're taking this virus, a vector, right? And you take out the virus's genetic material and you put this microdystrophin inside the virus, and you do the IV injection, right? So when Dr. Jerry Mendel in Nationwide Children's Ohio, when he first give me 1 minute, please. So when he first started dosing the boys, so he had, he knew that there was these boys who have mutations from exons 1 to 17 and they were increased risk of, and then also back here, 57 to here, they may have some, immune mediated reaction. At the time, we didn't know much. There was no clear understanding of why that would happen. So, but still, he excluded them. But as time goes on, when they did the phase 1 again, but Endeavor trials after, they included all boys. So there's two side effects that had happened. The main important one is what's called immune-mediated myositis. So which is inflammation of the muscle. So these boys who got, they get acute weak, meaning very sudden onset muscle weakness, not the weakness that you see in Duchenne. It's sudden worsening of the weakness, muscle pain, and along with that some breathing and swallowing problems that which is acute, happens within a day or two. And with those boys, when you you have to treat them with IV steroids. They may also need what's called IVIG and other immunosuppressive treatment. So what we had learned from that was this happened only in boys who patients within the exons 1 to 17. And when you even further pin it down, it had happened only in boys who had any sort of deletion involving exons 8 and 9. And the reason was, so the myositis, the immune reaction was actually to the transgene, the actual gene that we are giving, not to the vector, not to the virus, but to the gene itself. So since there's a reaction to the gene, what happens is it makes the gene ineffective. So it doesn't make any more protein, so the gene therapy doesn't work. It crosses out the action. And then on top of it, the kids are getting, because of the immune reaction, they're getting more weaker. So they're getting even worse and not coming back to their baseline weakness wherever they were. So I think that is the main reason that that now we are we are excluding those boys. So if you look at the Elevidys, the Sarepta's gene therapy that was approved, if you look at the FDA's prescribing information, boys who have mutations in exons 8 and 9, they're excluded. If you have mutations within 1 to 17, not 8 and 9, we can still include them, but they are at high risk of developing this immune-mediated myositis. I don't know if that kind of answers the question. And part of the explanation is also if the transgene, the gene that you're using in the gene therapy, if that microdystrophin has the exact same region as in this exons 1 to 17, that you're at increased risk of having this immune-mediated myositis. It's mainly that immune reaction is the reason to exclude those boys.
Thank you, doctor. Thank you very much. One parent wants to know if is there any medicine available for exon 18 and 19? And same for what treatment is available for exon 8 and 9 deletion?
Right. So that's so right now in terms of, of course, the steroids are standard of care, right? So steroids, you can use any steroids, prednisone, deflazacort, vamorolone. In terms of if you're looking at the gene transfer therapy, in this point of time, there's nothing specific for kids who have exons 8 and 9 deletion. But there are plans to start doing clinical trials for those boys in the future with additional, right now when you do gene therapy, we, on top of what steroids that they're taking, we give them additional steroids for about 2 to 3 months, depending on which program you look at, 2 to 3 months around the time of infusion. They start a day before infusion and you continue that for about 2 months or 3 months, additional steroids. So that's to proactively work on or prevent the immune-related side effects. So if you have to use this, if you have to try on this 8 and 9 deletion boys, they're going to add even more immunosuppressants, additional to steroids. Maybe there are other immunosuppressive medications that medicines that can be used. So that trial is in the preparation. I would say maybe in the next year or so we may be able to see that clinical trial coming up for those boys. And of course, you can use, there are other again on treatment trials that are being looked at, not genetic therapies, but more of therapies focused on preventing muscle damage and muscle fibrosis. I don't know if you guys heard of Edgewise. Edgewise is a company that makes this product called EDG. It actually works on, it helps with preventing the muscle damage and muscle degeneration. So that's something that can be used for those boys. In terms of exons 18 and 19, I think you can still, it's only 17. I know it's kind of close to 17, but exon 18 and 19, the gene transfer therapies are still can be used. And I don't think there's any exon skipping strategies that's being looked at for these exons either, at least in this point of time.
Thank you so much. Yeah. So
So
there's,
can I ask a question?
hello.
Hello.
Yeah, I'm taking the questions one by one, ma'am. So if you can, may I know who is this? You can raise your hand. Then we'll
My name is my name is Prajisha.
yeah, if you can just raise your hand, I'll just finish this question and come to you.
Ma'am,
Just
if
yeah.
possible, please ask them to put it in the
chat, yeah. Doctor,
Okay. Okay.
yeah, the next question is, for duplication genes 57 to 60, all genes in chain duplication, which treatment will be best? Which is more accurate and result giving? And what
Okay.
research is going on for
Sorry, can you
duplication
repeat that?
of, genes 57 to 60?
Okay, can you repeat that question? Sorry, I missed that.
No, for duplication genes 57 to 60, all genes in chain duplication, which treatment will be best? And which will produce some results? And what research is going on? Can you please guide?
Sure, I think any duplications, including 54. I think there's another one 50 to 55 or 54 to 57. The duplication of exons. Again, in the US, the in terms of the gene therapy that's approved, and also the gene therapy programs, all of those include those duplication patients with an exon duplications. I don't think that's a that's an exclusionary part. Of course, you would definitely have to use the steroids, deflazacort or prednisone, based on their weight. There's standard dosing that we use. If you're using prednisone, it's 0.75 milligram per kilogram. If you're using deflazacort, it's 0.9 milligram per kilogram. Again, of course, you can discuss with the physician to which steroid and what dosing would be important. But again, for duplication, there's no contraindication. You have gene transfer therapies. You have the in the trials, you have to use steroids. Some of the other, like the muscle targeted therapies that I told you about, those all can be used.
Yeah, thank you, doctor. And there's a question in the chat that says, the son is 9 years old, and when will they get gene therapy for that? The exon deletion is from 45 to 54.
54, yeah, I see that. So right now it's it's approved for 4 to 5, right? But there are clinical trials, the Sarepta's clinical trials doing on ex-US, outside of US. I have to look what are the countries that they do. They're actually looking at gene therapy for old boys older than 8. So that's actually ongoing right now. And at least in the United States, the plan is to expand the label. Sarepta is going to go talk to the FDA with the results that they had from the most recent phase 3 trial called Embark. They're going to use the results and talk to FDA to see if they could expand the label to include older boys also.
Okay, thank you. Is K.A.P 1000 Capricorn trial include these deletions? Does it include these deletions?
Yes, so Capricorn trial does include that. They don't have any exclusion based on the genetic change. They include boys, but yeah, they will include the deletion, including exons 1 to 17, 45 to 54, and others.
Another parent wants to know, their son has 50 to 55 duplication gene. Is there any medicine for it? Because presently they're giving 19 mg deflazacort.
Yeah, I think I can answer that. So there's no specific medicine for duplication. Of course, the gene transfer therapy that we talked about can be used in those boys. Steroids, again, based on your kid's weight and also how are they tolerating? You could use deflazacort. I don't know. What's his current weight to say if 19 milligram is enough. If you have the current weight, I can kind of talk about that. The dosing is usually 0.9 milligram per kilogram per day. If there are any side effects to it, we may slightly decrease or something, but that's pretty standard dosing. It's 0.9 milligram per kilogram per day. I
So,
think, yeah.
I could hear me. I'll just repeat that. Can you please throw some light specific to Rh74 antibody testing?
Sure. Yeah, I think, when we do this the gene transfers, right? So we want to make sure that the vector that they're using, the virus vector that they're using, we can be pre-exposed to those viruses, like, just in the environment. So you want to make sure they do not have pre-existing antibodies to those vectors. So, for example, in Sarepta program, the vector that's being used is AAV-RH74, right? So that's we want to make sure that we do not have pre-existing high antibodies, because if you do have that and you treat them with it, the therapy won't work. The antibodies cut down the effect of the therapy, and the side effect also gets worse. So, as far as testing goes, I don't think the key is, each company has different method of doing the testing, or different assays that they use, and also the cutoff value that they have is different based on what company. So for AAV-RH74, it's specifically the assays that developed by Sarepta, and right now it's being only done in the United States, and in a lab called Athena. I think that's the only way that we have right now to do the testing. For Sarepta has a sponsored test program for specific age group 4 to 5, but there are other age groups can be tested through out of pocket cost here in the United States. I don't think I'm not sure there are any labs that's in India that's doing that. Even if some labs say that they're doing it, I don't think that's accurate.
Thank you, doctor. Another parent wants to know that their son is having duplication in exon 39. Is there any medicine or gene therapy that exists for them?
Yeah, I think it's in terms of exon duplication involving exons, any gene transfer therapies that are being studied in the clinical trials as being approved. It's all it's all available for them.
Now the parent is giving 20 mg Visolon as prescribed by doctor for that child.
Okay, which one was that?
PP,
okay, the duplication. Yeah. So steroid, I think I can re-emphasize that. So steroid is a standard of care. Even with the, none of the treatments that we have right now is a cure, right? So none of the treatment, even the gene transfer therapy we have, it's going to fix the disease. It's not going to stop the progression. All the treatments that we have, they're only going to slow down the progression of the disease. So I don't think we are, steroids are not going to go away in the near future. Even if you treat them with gene therapy, they're probably still going to be on steroids. So irrespective of whatever genetic change you have in the DMD gene, steroids is the standard of care first-line treatment. So that's standard of care. So we have to do that because we know we know for sure, I know there are side effects to it, but the benefits are more than that, right? We know there's going to be it's going to prolong the duration of ambulation. It's going to delay the loss of ambulation. It's going to delay the delay the onset of cardiomyopathy. It's also going to delay the onset of respiratory muscle weakness and also prolong the lifespan.
Thank you, doctor. And what about older boys? When will gene therapy be available to them?
Yeah, so I think there's the clinical trial for at least Sarepta is going on right now, like I said, for boys 8 and older up to any age, both non-ambulatory and also what we call late ambulatory in the United States and also outside of United States. I think in the United States, the recruitment is completed, and in the outside of United States, in some countries, they're still recruiting. Once that trial is done, I think that's when we know. But Sarepta is hoping to talk to FDA to see if they could expand the label to include everyone. I think along those same lines, I saw some questions about how can we, access these treatments in the United States? I think it's a tricky question, right? If you want to participate in the clinical trials, that may be slightly easier. You just, again, from a clinical trial research perspective, you can obviously, try for some sort of, visiting visa or medical care visa or something like that. And the company has to be willing to accept international patients, whatever company that's doing the trial. And most of the times, if they're willing to accept international patients, they pay for the expenses in terms of your travel and your stay in the United States. If it is a gene therapy trial, most of the sites would want you to stay in the United States, close to the site for at least 3 months. So you have to be prepared for that, and then you would have to come every few months to the United States for the studies, for the trial itself. There are some companies that may come back and say that we won't accept any international patients, especially if it is a gene transfer therapy. And the main reason for there is they don't want, because so it's not the gene therapies are not one-time done deal, right? There's a lot, because of the safety issues that come from the gene therapy, there's a lot of close follow-up needed, monitoring needed, and they don't want, it's not safe for the kid to get the gene therapy and just leave. So they're kind of, from the company's perspective, and also from the treating physician perspective, they're afraid that they're going to get the treatment and they go and they don't come back and follow through the trials. So that's from a research perspective. From a if you don't want to do research but you want to get them treated, that's a bigger challenge there. It's possible. The only way is to raise funds and pay out of pocket for the medicine, and also for the care that the close monitoring that they're going to get, all of those in the hospital. So for example, this Raptors product that that's approved right now is about, it's $3.2 million US dollars, right? And then on top of it, you're going to have, in this point of time, if you want to get any sort of treatment outside of clinical trials in the United States. I know some companies are having discussions with some of the foundations like BirthMD, and also with the Indian government, to see make some of these accessible. I just don't know how long that's going to take.
Yeah, thank you, doctor. And this one question we have received, they say that the 10-year-old son report says hemzygous deletion has been observed at DMD gene exon 22 to 24. So what does it mean? Is it LGMD or DMD? And what changes can they expect in the near future? Is there any test or medicine that they should go for?
I may have to look at the report. If they have, I'm happy to look at it, or they can email me and respond back. The actual genetic testing report. If it is in the DMD gene, it's probably DMD, but I just want to look at the report if I can.
Yeah, and most of them are asking treatments for deletions for 45 to 52, 19-year-old DMD, or also for 49 to 55 deletions. Any treatment like gene therapy, and if it's possible in India or abroad?
Yeah, I think, in terms of gene transfer therapy, like I said before, in the abroad, for the older boys, it's still being ongoing. The approvals may take some time. There are some hospitals that would do what we call off-label treatment, if families understand the risks. And off-label meaning, even though the FDA label is 4 to 5, sometimes the physicians are comfortable dosing them beyond that, dosing older boys. It's up to the physician and the family discretion. In those scenarios in the US, again, like I said, you would have to it's a self-pay. You would have to raise funds and bring that.
Yeah, a parent wants to know, does Capricorn help skeletal muscles?
So the trial when they first when they first started the trial, their hope was to mainly focusing on the cardiac muscle. But when they started that, they also initially in the research, they also realized that it actually helps with the skeletal muscle also. And I think that's what they're doing now. Their focus is mainly on the skeletal muscle. It is a cardiac, it's similar to stem cell, but it's cells derived from the heart cells, and it's IV infusion given every 3 months.
So I think some questions have been repeated when people ask again and again about 49 to 55 deletion. Can you please suggest gene therapy is good for them? And how good are the results of the ongoing gene therapies that are there?
Yeah, so I think in terms of the how good are those, it's a wide range. Let me see if I can actually show you some of the results, may be helpful. All right, I'm going to share the screen and see if I could. All right, are you guys seeing that screen? Okay. So if you look at this is this is the result from the first 4 boys treated with this Rutgers product is phase 1 trial. This is they have good dystrophin expression. The mean expression is about 74% of normal, meaning in these boys they have no dystrophin, right? Boys and take an average of those, it's 74.3%. But there's a wide range, there were some of them had 75, some of them had even 10 to 15%. So it's a wide range, but it is a good dystrophin expression. This is an example of the muscle biopsy, like looking at the microscope here. This is before treatment. So the red lines that you see here, those they represent the dystrophin protein in the muscle membrane. So if this is pre-treatment, you see there's no red lines. This is after 12 weeks after treatment, and you see this red line. So it is dystrophin expression is there. Again, it is quite variable. And the same 4 boys, this is a functional improvement that they had seen at 4 years. So NSAA, I don't know how many of you have heard of that. It is a physical therapy assessment, North Star ambulatory assessment. It measures about 17 items of how good they walk, how good they run, how good they stand up. And if you look at the blue line as represent the boys, the mean score of the boys who were treated, and the purple line here is boys who were not treated. If you look at the NSAA score from baseline when they started the trial after the infusion, and to year 4, there is this improvement, and the ones who were not treated. So there's a huge difference between significant difference between the ones who treated and not treated. Now, again, it is going to be variable. There's going to be some who respond well with dystrophin expression, as also with the functional improvements, and there's going to be boys who may not respond as well. Like I said, it's not a cure. So it is going to be variable depending on depending on the kid.
There's one more question is prednisone stronger immunosuppressant than deflazacort?
Oh, so as an immunosuppressant, okay. So I don't know if the question is surrounding the gene therapy clinical trials. I think they both are steroids. Both have immunosuppressive effects. I don't know if we have comparisons to say one is stronger than the other. But in terms of if you're asking why, if you look at the gene therapy clinical trials, they were used only prednisone. The baseline steroid could be anything. It could be prednisone or deflazacort, but the proactive or prophylactic immunosuppression that we use is only prednisone. That's because they just in the clinical trials they just chose to do that because we have used it in other diseases and stuff. So that's why it's always prednisone. We haven't done that using deflazacort. That's why we don't recommend doing that. in the gene therapy trials, and also when you treat them commercially.
Yeah. What is the state of gene editing using CRISPR for treatment of DMD? Can we expect any breakthrough in this area?
So I think CRISPR's gene editing is still in the what we call preclinical stage. It's I don't know if you heard about this most recent death in the United States in the Boston area using a gene editing technology, CRISPR, in an older boy with Duchenne. So since then, I think that approach it's still ongoing, but it's kind of slowed down. So it's probably going to be another 4 to 5 years before we see any sort of breakthrough in the gene editing.